La siguiente presentación, cuyo título es Generación de evidencia en vida real y sus limitaciones estadísticas, va a estar a cargo de la profesora María Pía Sormani. María Pía es profesora de bioestadística en la Universidad de Génova en Italia. Es experta en temas relacionados a estadística y su aplicación a la generación de datos de vida real, con lo cual va a ser un placer escucharla y aprender de ella. Adelante, María Pía, y muchas gracias por haber aceptado participar.
Hello, good morning, and good afternoon, everybody. In this talk, I will touch about statistical issues related to real-world evidence data collection. Here are my disclosures. So, as you know, in these last years, there was an explosion of registries in MS. MS is a chronic disease, so it's a very frequent disease, so it's pretty easy to start and to collect data on MS patients. Here there's a classification of registries classified according to the number of patients. As you know, there are very large registries. The biggest is maybe the big MS network, that is a collection of 5 different registries. Of course, the MS base, that is a collection, an international collection of MS data. And then there are other classifications according to the maturity of data. There are very old registries. The Danish MS registry was set up in 1956. Also, the British Columbia MS database has a long history. And there are many other, also the Swedish registries, it has a long history. Another key of classification is according to the depth of variables included. There are some registries collecting also genetic data and immunological data. So in this context, the Argentinian registry is a new initiative that has have collected already 4,000 patients and collects data from more than 40 centers in Argentina. So this is a very good initiative. And as I can give a personal opinion, I prefer much more the national registries than the collection of international initiatives, because I mean the data within a single country are more homogeneous. The rules for treatment are the same along the country. So usually the registries in a single country are more homogeneous and better than larger collection of data. Anyway, of course, registries has some limitation. First of all, in the definition of registries. A few of these registries that I presented are truly population-based registries. A population-based registry is a registry that collects all the people with a specified condition. Most of these registries are large databases collecting a sample of patients with MS, but not all the patients in the country. The Danish registry is an exception because, of course, Denmark is a very small country, so they were able to set up a registry collecting the data from all the Danish patients. Also, the Swedish is a population-based registry, collecting more than 90% of people with MS in Sweden. So the definition of registry is not really appropriate. We are talking about very large databases. Other limitation is that very often the collection of the data was not based on a specific hypothesis. And also the selection criteria of patients sometimes are not very well defined. Registers often are based on what we have criterion. Let's collect what we have. And an example of this limitation is the missingness of the MRI data that very often happens in MS registries, because MRI data are difficult to be collected. There's problems of harmonization across different scanners. So, I mean, MRI data are very often missing in these registries. Another issue is harmonizing data from different cohorts. that is problematic because there are different platforms, there are different data elements, even if this issue is not so crucial for MS, because for MS, the data collected are pretty homogeneous in terms of what kind of data are collected. For example, EDSS is collected in every registry. The problem here is not in the kind of data that are collected, but how they are measured. So I will show you some examples in which, of course, EDSS is collected in every register, but sometimes EDSS is measured in a different way in different countries and in different parts of the world. Of course, there can be inconsistencies because the evolving diagnostic criteria, so data collected many years ago can have different threshold, different, patients with MS were diagnosed with MS with different criteria in the past. So there can be some heterogeneity, especially for registries with a very long history. And finally, the main issue that we have when we want to run comparative effectiveness using data, using real-world data, is the lack of randomization. We have data in registries. If we want to compare the efficacy of treatment, the effectiveness of treatments using real-world data, the issue is that the treatment were not randomized. So patients were treated with that treatment for a reason that is usually linked to their prognosis. So it's very difficult to compare treatment, and of course biases can affect the results of our analysis. There are ways to try to correct for the lack of randomization, but we will see that these methods are not always completely effective in correcting for that. So this is a typical slide that is presented when we talk about registries and real-world data. That is the comparison between randomized clinical trials and registries, even if we should think at these two approaches not as competing approaches, but these as complementary approaches. The randomized clinical trials and registries has a complementary role in research. Anyway, of course, the pros of randomized clinical trials is that they are the gold standard for comparing treatment efficacy because we don't have any confounding due to randomization. The cons are well known. We run randomized clinical trials in highly selected patients, in highly selected centers. So the findings are not always generalizable to real-life patients. Very often, the efficacy assessment is based on surrogate endpoints that can be measured quickly, like MRI endpoints, instrumental variables, but that sometimes are not exactly what really matters for patients. Randomized clinical trials are very expensive. They require a very long time to be planned and to be completed. So a lot of years and a lot of money to obtain results. Also, this is a relevant issue. They are motivated by economic reasons rather than by patients' needs and interests. Very often, sponsors run clinical trials in order to get an economic benefit from the results of the trial. And in general, the results are not applicable to all the real-world patients. On the other side, registries collect unselected populations. Findings can be generalized. They are based on hard endpoints, very long-term follow-up with disability, mortality as endpoints. They examine very large cohorts and are generally inexpensive as compared to the cost of randomized clinical trials. But for sure, we have a lot of issues, especially for comparative effectiveness, with data quality, missing variables, confounding factors, and the need to run multivariable statistics that sometimes is difficult to interpret. So let's examine now some examples of weakness of observational studies versus randomized controlled trials. So I will focus my attention here in comparative effectiveness because of course, the role of real-world evidence and observational studies is not just comparative effectiveness. Safety is I mean, the main issue that can be addressed with observational studies. I will show you some limitation of observational studies with some examples. So first of all, there are usually issues with the research question and the analytical approach that in randomized controlled trials is pre-specified in the study protocol. Sometimes, I mean, the methodological issues, I mean, are adapted to the data we have rather than pre-specified. Then we have data quality and collection problem and outcome assessment heterogeneity. While in randomized controlled trials, everything is standardized, outcomes are uniformly assessed by central reading usually. And I mean, while we in observational studies collect data that have been assessed by different observers in a non-fully standardized ways. And finally, of course, I will show you some example of the role of confounding factor in the exposure to bias that is not present in randomized controlled trials because they are randomized. So this is an example of the heterogeneity I was mentioning before regarding on outcome assessment. So EDSS is collected everywhere, but I mean, it is measured in a different way. To assess the heterogeneity of EDSS assessment, we collected data from 3 clinical trials and we examined the EDSS progression in the placebo arms of these trials. These trials were the lakinimod program. As you remember, the lakinimod program was negative in the end. Lakinimod was not registered for its use in relapsing remitting MS, but we collected just the placebo arms of the trials and examined the rate of EDSS progression in 3 different areas of the world. Western Europe, about 300 patients, Eastern Europe, more than 1,000 patients, and USA and Canada, 155 patients. So 3 different areas. And this is the rate of EDSS progression over 2 years for patients who entered the same trials with exactly the same inclusion criteria, just because they were in USA and Canada, Western Europe, and Eastern Europe. This difference remained also after adjusting for baseline covariate, but the baseline covariates were pretty similar because the inclusion criteria of the trial were the same. Note that the rate of EDSS progression that was 20% in USA and Canada was double the rate of progression we observed in Eastern Europe. So this large effect is larger than the effect of any drug we are used to on EDSS progression. So this is not an issue in a randomized trials because everything is balanced in a trial. So you have the same number of patients from USA and Canada in both arms. But this cannot be the case in observational studies, where maybe you can have patients treated with a certain drug all coming from an area of the world, or more patients treated with one treatment than in other countries. And I will show you an example of that. So this is a true issue we have in non-randomized studies, collecting data, especially from different countries or different regions. This is a plot that was taken in my centers just to show you how EDSS assessment is heterogeneous also in the same centers but between different examiners. This is a plot of an EDSS of 2 patients with MS. And we noticed that this is just 2 of them, but we noticed this drop in EDSS between 2013 and 2014, 2 points of EDSS drop in many patients during this period. So the only reason for that was the pregnancy leave of the neurologist who had these patients in care. And so during this period between 2013 and 2014, these patients were visited by another neurologist who was more optimistic and scored them with 2 points less of EDSS. So of course, this is an issue because patients were in the same center, so in the same setting, but just visited by 2 different observers. And the example I was mentioning before, this is a paper that was published in Lancet Neurology from MS Base, comparing alemtuzumab with other drugs, with natalizumab, fingolimod, and interferon beta, in a group of relapsing remitting MS patients. And this study enrolled patients from MS base. And since in MS base there were no patients treated with alemtuzumab, the MS-based patients were compared to the UK cohort treated with alemtuzumab. So the issue here is that alemtuzumab was, all the alemtuzumab patients were from the UK, while all the people treated with other drugs were from MS base. And in MS base, there were no centers from UK. So, you know, the difference between alemtuzumab and the other drugs can be because of alemtuzumab is different, but also because maybe there's a country effect that we cannot adjust for, because if all the alemtuzumab are from UK, we cannot assess a UK effect. So, I mean, this study is subject to this possible bias of a different EDSS assessment in different countries. So, to summarize the issue of outcome assessment heterogeneity, we must be very careful when we run comparative effectiveness studies research when we use multi-center and multinational registries. And if we are doing that, we must allow to adjust for the center and the country effect. If not, the results can be strongly biased. So, since I am a statistician, I must mention the propensity score adjustment. That is the most widely used method to adjust for imbalances between the two arms, the two groups, the two treatments to be compared. The lack of randomization, of course, requires to adjust for differences in baseline factors. We can do that by multivariate analysis, but we can do that also by a propensity score approach. I will show you that this adjustment method is, of course, effective, but it can be not fully effective to eliminate confounding. Because, of course, there are what we call unmeasured confounders, so confounders that we're not aware of, or maybe confounders that we are aware of, but we cannot measure. And also we can have post-baseline confounders, some differences that arise after the start of the treatment. What is a propensity score? So here you see what is a classical multivariate analysis. We assess the treatment effect on the outcome after adjusting for all the baseline variables, age, sex, disease duration, EDSS, and so on. This is the classical multivariate analysis. With propensity score adjustment, we use a different, even if very similar approach. Instead of modeling the effect of treatment on the outcome after adjusting for all the other variables, we take the treatment as the dependent variable. So we take a binary variable, treated versus non-treated, and we search for the best combination of baseline variables that distinguish treated versus non-treated patients. So we build a score describing the propensity to be treated. Then we run our analysis of the treatment effect on the outcome, adjusting for the propensity score. So, you know, it's the same approach, but instead of using each variable one by one, we combine them with the best combination describing who's treated and who's not treated. This is the propensity score approach. So the message is that the propensity score approach is not a magic, is not better than multivariate analysis. It's just a different mathematical approach to the same problem. In this slide, I try to draw what is a propensity score matching. Once you have calculated the propensity score for all the patients, you select just the patients who have overlapping propensity score in the two arms, and you eliminate the patients who has a propensity score that is not matched in the other arm. This is propensity score matching. The propensity score matching reduces the sample size because it eliminates the patients that are not matched according to the propensity score. And here is an example showing you how propensity score is not able to adjust for residual confounding. This is a study that was published in JAMA Neurology in 2012, and it's an analysis coming from the British Columbia database, so a very large data set of patients followed since many years. And at that time, the issue was to compare the effect of interferon beta, of treatment with interferon beta with no treatment on EDSS progression. So in this kind of study, comparing treated versus non-treated patients make it easy to define the treated patients because they are those who were treated, and time zero is the time when they started treatment. A little bit more difficult is to define the untreated patients. So the authors in this paper choose two different cohorts. The first was an untreated contemporary cohort. So they selected 800 patients in the same period of the treatment cohort, so from 1995 to 2004, who were contemporary, but they were not treated. And they also choose an historical control cohort in which they choose patients who were untreated because treatment was not available at that time. And here are the results of the analysis. They adjusted the analysis with propensity score. So the statistical analysis was very well done. And then you see here the variables included in propensity score. They also used time varying covariate. So it was a very good analysis. The outcome was time to reach EDSS-6. Here you see, in the first panel, you have the comparison with the contemporary cohort. And the interferon beta, the effect of interferon beta, with an hazard ratio 1.3 indicated that people treated with interferon has a worse outcome than untreated people. The hazard of progression was 30% higher in treated versus the untreated patients. The opposite was true for the historical cohort. People treated with interferon has a probability of progression that was 30% less than untreated people. So what's the issue here? In the contemporary cohort, if people decided not to be treated when the treatment was available, this was because they were probably very mild. They had a very mild disease. So patients with a better prognosis decided not to take the treatment. And even if there was a correction for all the baseline variables, the advantage of untreated people over treated people remained, a 30% benefit. This was not there for the historical cohort because, I mean, untreated people here in the historical cohort, I mean, were not treated because they didn't have the treatment. But we all know that the historical control can be tricky because more contemporary cohorts usually have a better prognosis than historical control, the Will Rogers phenomenon and the historical control bias. So we don't know if this 30% benefit is due to a real effect of interferon, we do hope so, or is simply an historical control bias. So, I mean, the full results of this study is that we don't know. Interferon-treated patients, two different cohorts, two different kind of controls, two opposite results. This is the demonstration that even if we could adjust for baseline factors, the confounding factors, the unmeasured confounding, can bias the results and give us different conclusions. And this is exactly what I was summarizing here. So the propensity score adjustment sometimes fails to fully correct for confounding, and we cannot check this failure in our data. So the only thing that we can do is to run many sensitivity analyses, changing some entry criteria, some inclusion criteria, the cohort to be compared to see how the results is stable, changing the entry criteria. And I have another example showing you the failure of the propensity score adjustment. Here, again, we use the placebo arms of clinical trials. You know, the placebo arms are very good to be used to demonstrate statistical issues because you know that for them, the null hypothesis is true. They are treated with placebo. So, I mean, you don't have, by definition, any treatment effect. We took the placebo arm of the AFFIRM trial. So, and we call this placebo 2006. And also the placebo patients enrolled in the DEFINE and CONFIRM trial. So we have the placebo 2012 patients. Of course, the baseline characteristics of these two placebo groups, even if the entry criteria, the inclusion criteria of the trial were very similar, were slightly different. But there's no problem. I mean, we can correct for differences at baseline. When we compare the progression-free survival between placebo 2006 and placebo 2012, we see that placebo 2012 is superior to placebo 2006, and the hazard ratio is 0.64. An effect that is comparable to the effect of natalizumab versus placebo, just to tell you that, I mean, the effect is very large. Okay, but this is an unadjusted result. Let's try now to correct with propensity score to see whether we are able to make this effect disappearing by adjusting for the baseline variables. So we run different propensity score approaches because, as you maybe know, there are some differences in different approaches. We apply a one-to-one propensity score matching, a one-to-n propensity score matching, an inverse probability weighting, other kind of inverse probability weighting, cutting the extreme of the scores. And here are the results. You see here, the first is the unadjusted results, hazard ratio 0.64. And if we exclude the one-to-one matching, in which we reduce the sample size, so we enlarge the confidence limits, so the treatment effects becomes no more significant, even if the hazard ratio is 0.78, all the other adjustments even increased the difference between the placebo group. So the conclusion of our study would have been that the placebo 2012 is much better than the placebo 2006, is superior to placebo 2006, and reduced the rate of EDSS progression of about 50%. So this is clearly impossible to be true, so we conclude that in this case, the propensity score adjustment failed to adjust for all the differences between the two treatment arms. Residual confounding, so the statistical adjustment cannot cure biases arising from confounding factors that we are not able to measure. So here are the conclusion of my talk, but I added another small section because, I mean, what I presented here are standard issues, a standard limitation of real-world studies. Remember, specifically related to comparative effectiveness. Of course, all these observations are not valid for safety studies in which you have a single arm and you observe adverse events. This is the main field of utility of real-world studies, I think. And if you think many successes came from real-world evidence regarding safety. Let's think to the PML. All we know about PML in natalizumab-treated patients comes from large observational studies. Anyway, for concluding the limitation of comparative effectiveness, even if we have a real-world study, we need a design to answer an explicit research question. We have issue on data and quality and collection, so it is important to check for heterogeneity before pulling data from different regions. Let's check if these data are homogeneous, if the rate of EDSS progression can be put together instead of making a big database of very heterogeneous data. This is because heterogeneity can be informative itself. If we have two regions with very different rate of EDSS progression, this can be a different way of assessing EDSS, and this can be cured, maybe training the neurologist to assess EDSS in the same way, or it can be indication of a different rate of EDSS progression in different regions, and this can be studied, and I mean, that this can be another research question. Finally, for propensity score or multivariate analysis, we must remember that it is not enough to adjust for a propensity score to be fully sure that the observed results is unbiased. It is important to run sensitivity analysis to try to estimate the possible impact of bias on the results and explicitly discuss this limitation in the discussion of our paper. So I want to conclude my talk with a quick glimpse to a new kind of analysis that is largely used in other fields of medicine, like in cardiology and also in oncology, but it was never used in MS. But I think we are ready to start it now. And that's the methodology of randomized registry trials. That is, randomized clinical trials based on registry data. So what is a registry-based randomized trials? It is an observational study where the only intervention is randomization. So you take patients you have in a registry, you select them according to the inclusion criteria, then you randomize them to 2 interventions, and you continue to follow them up according to the procedure you have set up for your registry, so in clinical practice. In this way, it is possible to have the advantages of registry data, real-world data, and the advantages of randomization. Of course, there are limitations and different fields of application. If you have a new drug, so the last line of this slide, we must run a randomized controlled trial because we cannot introduce a new drug in clinical practice. But for example, if we have to compare 2 different treatment strategies, let's say cladribine followed by interferon or interferon followed by cladribine, or I mean, different schedule of treatment assignment for treatment already approved, the registry-based randomized clinical trial is the best option. If we have to test a device that is already in use, but was never tested in a randomized trial, we can randomize patients in a registry to use or not use the device. Of course, if the device is first in man, we need a randomized controlled trial. Also, drug usually used in clinical practice, repurposing of drugs can be studied in registry-based randomized trials, or a drug that is already approved, but that should be tested for a new indication. This can be tested in randomized trials and in registry-based randomized trials. So here is a list of situations where the registry-based randomized clinical trials is the ideal instrument for repurposing of drugs, for drugs which might have indication for another condition, for different investigative techniques, for interventions that are not really drugs like diet, exercise, supplements, and so on. And please consider that all these conditions are relevant for progressive MS studies. That is, I mean, where we lack new strategies. So in my view, running studies in progressive MS, maybe combining different approaches, can be done much better with registry-based randomized clinical trials than with standard randomized clinical trials. Just to give you an example, okay, these advantages and limitations I have already explored that. To give you an example of the advantage of a registry-based randomized clinical trial, this is an example taken from cardiology, where 2 different approaches were compared for patients with cardiac problems, so PCI only and PCI plus thrombectomy. These 2 techniques were used in clinical practice. So in 2010, a registry-based clinical trial was run, the TASTE trial, and just a few months after, a randomized clinical trial was planned. If you look at both studies demonstrate that the 2 techniques are equivalent, so the thrombectomy is not useful if added to PCI. Note the difference. The start was the same at the same period, but the paper of the registry-based trials published on the New England Journal of Medicine was published in 2013 as compared to the randomized trial published in 2015. So a gain of 2 years as compared to the randomized clinical trials. But the most important thing is the cost. The registry-based trial was run with 350,000 euros as compared to 50,000, okay, 15 milioni euros in the randomized clinical trial. So order of magnitudes of difference. And this is really important. We all know the cost of a randomized clinical trial that can be cut using a registry-based strategy. And I think this is my last slide. I mean, I wanted to present you this part of registry-based randomized clinical trials because I think that all the people running registries should start thinking to plan randomized clinical trials based on the registry. I think that the time is mature for MS. So we have many registries. The quality of these registries has improved. So I think it's time to start this approach in MS. And this is my last slide, and I thank you for your attention.
Thanks a lot, Maria Pia, for your amazing and very comprehensive presentation. And I have a question for you. Considering the limitation of the registries, the bias, the confounding factors, the limitation of statistical analysis, can we really believe in real-world evidence?
Okay, my answer to your question is, of course, I mean, all these issues are more related to the comparative effectiveness when we want to compare to different drugs. In my view, I mean, I prefer to stay on the results of randomized clinical trials, and when these randomized clinical trials are lacking, maybe to run indirect comparisons of results of clinical trials for assessing the relative efficacy of drugs. I think that real-world evidence is incredibly important for different issues, like safety, first of all, safety, or studying a specific part of the population, pregnant women, older people, what happens in this population, information that we don't have in randomized clinical studies. But safety is the most important thing. And also, you know, it's typical of pharmaceutical company to be very worried about the relative efficacy of two drugs. Is fingolimod better than dimethyl fumarate? This is 0.5, 0. I mean, I don't think this is so relevant. They are both effective drugs. What is important are the side effects. So if one of the two has a better safety profile, it can be preferred by patients. I mean, it's not the small difference in the relapse rate reduction of the two drugs. So, and safety, you know, I was thinking, I mean, I mentioned PML, but all the information we have for PML comes from observational studies. We have now a risk profile, and we have guidelines on how to treat natalizumab patients, and this came from observational studies and large databases. So, I mean, I think, I mean, we have drugs. Let's think to cladribine. We have data from clinical trial over 2 years. We don't know what's going to happen after the 2 years course of the study. Also, I mean, all the information about the safety of alemtuzumab, I mean, all this emerging evidence comes from real-world studies that are very relevant for that.
Yes, of course. Juan, do you have a question?
Yeah. I'd like to hear you in two comments. One is related what you already mentioned, and it's about you already express about effectiveness, and the comment is related. What is, since your perspective, the most important of registries? I mean, you already mentioned that probably effectiveness, it's not the most relevant of registries. And since your perspective, which is the most important from registries? And the other one I'd like to hear you is, you mentioned that probably transnational registries is not the goal. Probably nationwide registries is what we should go for. And I'd like to hear your opinion relate. Do you think that core data set from registries would be a good idea to share between countries in order to have an homogenized core data set to be shared from every country in order to then later be able to share core dataset registries, despite every country then later would want to gather every information from their countries, but probably a core dataset to be able to then later be shared from all registries. Do you think that would be a good idea?
You know, just to respond to both the question, as I told you previously, safety is the main goal of registries, in my view. Safety is very relevant for patients, especially with these new, very potent drugs that are very effective, but I mean, they have side effects that can manifest themselves on the long run. Regarding, I mean, the multinational and combining data, there's such a sort of obsession in having very big data set. I mean, the important thing is to have very good data. And I mean, the number, the sample size depends on what you want to assess. Very big data are useful to assess very small differences. And sometimes this is not what we need. I mean, I'm not interested in see a small difference between dimethyl fumarate and fingolimod. You know, just to give you an example, the bone marrow transplant, that is a technique that has been very often compared using real world data, because I mean, there are some new clinical trials running, some clinical trials have been published, but it's very difficult to run a clinical trial with bone marrow transplant, randomize patients to bone marrow transplant or a different drug. So many data come from real world data. We don't need a huge data set, because if we want to see the effect of transplant, we want to see a very large effect, because otherwise transplant is not worthwhile. Mm-hmm. You know, so it's much better to have a very well characterized data set with good data rather than a big data set, because you know, I always hear, oh, our data set is larger, 2,000 million. Okay, but and regarding combining data, okay, let's think to a meta-analysis. When we run a meta-analysis, we combine data from different studies, but the first thing we do is to assess homogeneity before combining. Yeah. So, you know, if you want to combine your data with other countries, the first thing to do is to try to assess homogeneity of data before combining. Because if you see that you're measuring different things, I mean, it's not so, it is better to try to understand why you are different from other countries or other groups or other. Okay, so it's fine to combine, but a lot of work must be done before combining to assess homogeneity, to try to understand if there are differences, why these differences are there. And that if data are very homogeneous, you can combine. But if you see large differences, you know, it's much better to try to explain these differences instead of creating a big, huge data set of heterogeneous data that dilute the effect that you are searching for. You know, so it can be dangerous. Heterogeneity masks the reality. So sometimes, you know, a single center, small but very well done data set is better than a huge data with a lot of missing data, a lot of data that are assessed in a bad way.
Correct. Perfect.
Yes.
Perfect.
Yes.
Very clear.
Yes.
Very clear.
Yes, of
Absolutely.
course. Yes, I agree with you. Unfortunately, we are on time. So, Maria Pia, we want to thank you again for being part of our activity and for sharing with us all your knowledge and expertise. And we hope to see you soon, for example, during ECTRIMS.
Yeah, for sure, for sure. It's for me, it's a pleasure to be here with you. You know, I had a very nice time in Buenos Aires last time when I came. You know, there's a very good feeling between Italians and Argentinians, so it's really a pleasure to interact with you always. And of course, I hope to meet you in ECTRIMS and to meet you in person.
Yes, yes, finally.
Yeah.
Okay.
Okay.
Thanks a lot.
Thank you very much.
Thank you. Bye.
Thank
Bye.
you.
Bye.